So, hello, good evening. I hope you can hear me. I'm Stefan Ihde. I'm giving this lecture from Belgrade, Serbia, that's in Europe, in former Yugoslavia. And I want to continue to talk a little bit about corticobasal implants, about this new way of implantology, which we have developed over the years. And first of all, I want to open my PowerPoint. I'm not sure if you see this now. Probably you should see this now. Huh? Excuse me. And well, Dr. Daniel has asked me to show again this invitation to the third Congress in Colombia, which takes place on 21st and 22nd of March 2025. This these congresses it was in Bogota and now it's in Cartagena. They are quite essential to visit because there very good speakers are going to give their lectures and you can learn a lot. I mean, this is only a webinar. This is an introduction into corticobasal implantology and on the Congress and of course in the courses, both in Bogota and on this very intense course, all in 1 week course in Serbia, you can get all the information that you have to know about this type of implantology. Now, what are we doing different compared to the osseointegrating tribe? We work with cortically anchored implants, so the implants is screwed into the cortical and it is fixated there. So we have a torque, we have a direct contact between the implant and the bone, and as per definition of Mr. Brannemark, this is called osseointegration. So the osseointegration is made by us. It's actually made by the surgeon, and we don't have to wait for this to happen. So this is one of the big differences compared to the between the corticobasal implants and the
No,
osseointegrated
no.
implants.
The
Um, I want to mention that if you have questions or comments, there's a chat, and you can write question into the chat. I don't see this constantly, but I see it every now and then. And if I see it, I will answer the question or discuss the question with you. And you are invited to participate all the time through the chat. So please leave your microphones turned off. Simply write into the chat, and I will then address the question or this topic. When we started this, or actually I started this project with the corticobasal implants or with these lateral basal implants approximately 1997. It was, of course, a completely different time, and I was lucky to be an implantologist already in this time because we had to work with completely different means. This means that there were implants available, of course, implants like two-stage implants, these Brennemark implants, Straumann implants, and so on. But at that time, there was no bone augmentation available. So the bone augmentation was added later to oral implantology. And this made it, of course, quite impossible to treat most of the patients. And most of the patients received implants where it was possible, so where they had enough of their bone of their own, and the other patients were simply not treated. So implantology at that time was, let's say, an exclusive experiment only for the rich, and it was not intended actually to treat everybody. So if I was when I was discussing this topic, I mean, we discussed this very often with the colleagues in work groups that basically implants should be for everybody. Everybody should have implants, over time. I mean, let's say with 50, 60, 70 to get implants and to remove the teeth so that our patients are going to be with the fixed teeth for all of their life. Now, as you can imagine, when I discussed this in the 1990s and in the early 2000s, everybody was only laughing because they say it's not possible, it's too much, too expensive, and nobody can afford. How can the cleaning lady afford to have implants till the end of their life? But I must say today in 2005, we are doing exactly this. So we are basically not excluding our patients for financial reasons. We also don't have to exclude patients from the treatment because of the lack of bone. We can also treat smokers because we don't have to do bone augmentation. So the smokers have the same chance to success like the non-smokers. We have no objections for medical reasons, except maybe this bisphosphonate, this type of chemotherapy for the bone, which is unfortunately given to patients which show signs of osteoporosis. So this is something that we cannot overcome, I would say, because the bone is severely damaged by this medication. And I suggest that we simply will talk to the gynecologists and to those people who administer these drugs for nothing. Now, I'm not saying that that the bisphosphonates are good for nothing. I'm just saying that patients are treated with bisphosphonate who don't have to get this medication. But this is a real problem. So the gynecologists seem to have forgotten about the estrogens and gestagens and other hormones for the treatment of osteoporosis. But now they basically use an oncology tool. It's a chemotherapy actually to try to solve this problem. And first of all, it doesn't work. And the second point is that this is, of course, I mean, throwing an atomic bomb on a mosquito. There's no way to do this, but they are doing this, so we have to inform them, talk to them to please stop doing this, because in the end, they are kind of eliminating the chances to fix these for all these patients. And I'm also sure that patients would take this decision if they would be fully informed. So to come back to the 1990s, when I started with implantology, there was no bone augmentation. Also, there was no CBCT available at that time. So we had to work with panoramic pictures. And this technology of the corticobasal implant, and of course also of the lateral basal implants, which we used in the beginning, was done, yeah, with a lot of experience in anatomy and with panoramic pictures, and it was nevertheless, of course, very, very successful. Now, what is the advantage of using the cortical bone? This bone is highly mineralized, and there's a low metabolism, so there's not a lot of remodeling in these bone areas. Means even if we put an implant there, we can expect that almost no remodeling will take place. We know this from the field of traumatology, where these little these little bone screws have been tested for function, and in the histology, I mean, they didn't see remodeling or almost no remodeling. These were experiments which were done already around 1975, so in the beginning of this all. So this was a quite basic experiment. Maybe that in 1975 the AO was formed in Davos. So this was it's called Arbeitsgemeinschaft Osteosynthesis. So it's like a work cooperation regarding osteosynthesis. So these were a few doctors, five in the beginning, who wanted to eliminate the gypsum after the ski accident, and they were fixing the fractures with blades and intermedullary nails and so on. So these are the people who really came up with the immediate loading, because this was all immediate loading, of course, what they did. And unfortunately, dentistry was far away from these beginnings of traumatology. So we kind of had no contact. Dentists didn't have contact. We didn't get the information. We didn't know anything about this. And also from our education from the university, I mean, from my university, I can tell this. I finished dentistry in 1987 in Würzburg in West Germany. And I had actually no clue about the bone when I left university, and I didn't have a clue because nobody was teaching anything. But if you come to the course, talking about the course in Belgrade, you will learn a lot about bone. You will understand how it works and why it works, and that this is everything that we are doing is based let's say, a deep friendship with the bone. We don't want to do anything that harms the bone. We don't want to annoy the bone. We want to keep the bone more or less asleep, let's say, uh, because if the bone is teased too much or is woken up too much, there will be metabolic reaction. There will be um, I mean, things will happen in the bone which we don't want to see there. It's much better, much safer to leave the bone sleeping or to leave the cortical with high mineralization and low blood supply. This is actually what we need. This type of cortical we need for anchorage of the implant, for immediate loading protocols. And we will show you in Belgrade how to do this, how to make sure that the bone hopefully doesn't wake up from the treatment that we give to them. It's actually the total opposite if you compare this to the strategy of the two-stage implants. If you, for example, look at the name SL Active, SL Active is probably a trademark of Straumann Company, and there's the word active. And this word active in connection with the bone, this makes me very worried. I mean, I don't want any reaction of the bone. I don't want active osseointegration. This is it's a completely different field of thinking. And I would say it's an unproven field of thinking. And the idea to get a deterioration of the mineralization of the bone and then to hopefully bring the mineralization back to how it was before, let's say within 1 or 2 years, that's possible. This was always worrying me. So I recommend not to walk in this direction, but to stay on the side of the corticobasal implantology, where we are not playing with any active surfaces or any all the activities which bone can do, undoubtedly can do, are unwanted from our point of view, from my point of view. Why this is so, you really have to come to Belgrade and to sit there and to listen 1 week, and this information will give you a thorough brainwash. Of course, we will tell you things which you didn't hear in the university. We will tell you things which which are basically new, but we will also, I mean, I can assure you that we will tell you things which are really true. I mean, we show you long-term statistics, and you will usually, typically during this week, also see surgeries where this is all done, and you will see this is a completely different story. This has nothing to do with osseointegration. It's a completely different field of implantology. Having said this, just a moment, let me just come to the chat to see what are the questions at the moment. Why don't I see this? Can you make the sound louder? Mhm. I don't know how to do this louder. I hope it is. Um, Sound louder. Mhm. Actually, I don't know how to do it, but I can speak louder, huh? If somebody has a clue or can give me an idea how to do it, I will do it, of course. But I'm not specialist with this Zoom. Now, having said that, I would like to come to the next topic, and the topic is what we can do with the implants. Now, traditionally, um, of course, dentists are putting implants if there are no teeth left or if there are teeth missing. So they put, first of all, implants between teeth in gaps. Some of them do tubular bridges, is mainly this all on four tribe or all on six tribe are doing tubular bridges with a lot of disadvantages if you do it that way. Uh, but we saw over the years, I mean, the more this became popular in our own patient clientele, in the clinics, for example, where I work, we saw patients coming in who simply requested the removal of all teeth. This was for me, of course, shocking. I mean, being a dentist or having been a dentist, that patients don't want to live with their teeth. And of course, this is not in accordance with the rule of the dental chamber. This is even also not in accordance with the rules which the universities are teaching. But I saw, and I'm sure today, that that this is the future of implantology, and the future is the replacement of the teeth by the implant at the appropriate age, and at the appropriate state of the dentition, destruction of teeth, destruction of the periodontal tissues, including the bone, of course. And this is something which we or you should consider as your task to come to your own conclusion or to listen to guidelines, for example, given by the IF, when the patient should be advised to move to implants. I mean, to extract all teeth and move to implants. I have to say, in the last approximately 7 years, I have done nothing else. I mean, this is our basic clientele. People who come in, we remove all the teeth. We remove, if there are also all two-stage implants, of course, because these implants are problematic. They tend to lead to perimplantitis, and of course, the patients don't want this. And we take these implants, all two-stage implants out, regardless if they are good or not good, because even a very good two-stage implants one day will be a bad two-stage implants. We only have to wait. And of course, we don't want to take this on our guarantee. So the switch of a patient from a tooth-based dentition to an implant-based dentition is a very interesting job. I mean, it's interesting also from financial point of view, but this is actually what the patient wants. And there we are in a completely new dentistry. This is not only an implantology question, but this is dentistry. So there are so many dentists like me who would never do a root canal treatment. We simply extract the teeth. We will not even offer the root canal treatment to the patient. We also do I mean, except for very mild cases of periodontal disease, we will never do a periodontal treatment. We will remove the teeth. Why do we do this? Because the periodontal disease can't be stopped. Once this has started, it will progress. You will learn in the lectures about the bone, why it progresses, why you cannot stop periodontal disease. So the only way to stop it is to remove the teeth, actually, and okay, you have to clean a little bit of soft tissue, but this is not the point. You can also leave the infection there. It will self-clean itself, and then the bone loss will stop, or even more bone will grow after this all is done. It depends on the, let's say, on the spatial arrangement of the bone. And that's why we don't do these periodontal diseases, because we by doing with the periodontal treatments, because by naming it a treatment and telling the patient, okay, we treat your period disease, we will, let's say, give him the hope that we can do something about it, that we can stop it. But of course, we cannot stop it. This period disease is unstoppable. It's like periodontitis. Also, it doesn't stop. It stops only after you remove the implant. With the endo treated teeth, I mean, I have, like say, I'm the special enemy of, of endo treated teeth, because I know a lot about bone, really a lot. If I know anything, then bone. And if I look at the bone around the endo treated teeth with open eyes and with the knowledge that I have gained throughout my professional life, I'm just shocked. I mean, it's so obvious what are the damages of this endo treatment. We see things which we will never see around a non-endo treated tooth. Of course, the ankylosis is another problem which will be created by endo treatment. So there are a lot of good reasons to rethink well, the question, what is dentistry? What should we do in dentistry? And my suggestion is that you will advise patients to opt for implants I mean, corticobasal implants, of course, at a certain age. It's of course clear that this switch to implants cannot be done with the two-stage implants. And why is this? Well, it's very simple, because the two-stage implants don't last that long. So, I mean, you probably know that two-stage implants are all this Straumann and Nobel Biocare stuff, has a survival period of about 8 to 10 years. And after this, most of the implants are out. So basically, these are temporary implant. Now, of course, you cannot remove a tooth, which is not so bad, by putting such a temporary implant in. This is, of course, not ethical. But with the corticobasal implants, the PCS, for example, we don't have this problem. We can remove any teeth, whatever we want, and the implant goes in and the implant stays, and this implant stays forever, and there's no perimplantitis. So we are working in a completely different field with completely different roles, also different experiences, of course. And I suggest that you will come sooner or later to the course in Belgrade, where we will give you all the necessary information about this topic. So my plan is now to look at this prospectus, which we have created for this all-in-one week course. It says here you are going to see the light, so we will really enlighten you regarding the question, what is implantology and how do implant works? And we will show you why conventional dentistry, you see, we talk about dentistry here, not only about implantology, is as such is a very doubtful occupation. We will explain you why all these prosthetic rules which you learn in the university are very doubtful. Why, if you make fixed teeth, let's say fixed bridges, for example, on teeth, you are in most of the cases making a mistake. Probably you don't know your mistakes at the moment, but we will show you what works and what doesn't work. So after this course, you will for sure reconsider putting crowns and bridges a lot. Of course, I mean, dentures are anyway not placed today, but even crowns and bridges are in many cases wrongly done, even you think it's properly done. But according to my experience, and I of course have also spent 5.5 years in a university, and I'm also teaching now in a university, and see what the prosthetic professors are teaching there. I would say this is a disaster. This has nothing to do with the modern, with the possibilities of modern dentistry. Okay, and dentistry without corticobasal implants is, in my way, unthinkable. You know, these two-stage implants is another story. Two-stage implants, they are in, let's say, 8, 10 years, maybe 12. Few of them are going to be in forever. This is also true. But if you ask the question, you know, I put 10 implants, how many out of these 10 are in 10 years in? And I would say not so many. Probably, you know, 4 to 5 are out. And this, of course, justifies that we are talking about temporary implants. And of course, as soon as you understand this, as soon as this goes into your brain, you will stop working with these implants, of course. No way to do this. Now, we are a number of teachers, and I would like to make you acquainted with this teacher. That's the Professor Vitomir Konstantinovic. He's professor of maxillofacial surgery and implantology, director of the Clinic for Maxillofacial Surgery. He's a first-class IF teacher, a member of the IF board. I know Professor Konstantinovic now already 25 years, so we started together working here in Belgrade in the year 2000, and we are very good friends and colleagues. We discuss a lot of questions around implantology. Next teacher is Professor Olga Šipić. She's prosthetic specialist in pathologist, also first-class IF teacher. She gives the lectures about mastication, about the prosthetic work. Actually, the procedures in her clinic here in Belgrade. So there are some of the lectures are given in the lecture room, and the other lectures are given in her clinic. Next is Professor Antonina Ihde, also prosthetic specialist, first-class IF teacher, and head of the dental implant faculty of the International Implant Foundation. She is talking mainly about prosthetics, actually 2 full half days or 1 day only about prosthetics, in combination, of course, with lectures from the laboratory, which we refer to the laboratory. I want to say also that we do all the laboratory work nowadays digital. So the bridges are milled on milling machine. They are first designed in programs like Exocad. We have a lot of protocols, and we will show you the most important protocols on how to do this, how to come to this model, to this STL file, which will be later manufactured. We work both here in Belgrade and also in Montenegro, where my wife and I have a clinic. We work with the full zirconium bridges only, so we don't do any metal composite anymore, but only full zirconium. And this means, of course, that we have surgical technologies. How we create the anatomy, and we can then create a bone level which is stable, and we don't have to work with temporary bridges. So we don't do any temporary bridges. We always put right after, yeah, tooth extraction, after implant placement, after the bone adjustment, we incorporate the final bridges, the final zirconium bridges. So patients are, of course, very, very happy to get this. They don't lose time with a temporary bridge. They don't have to come again. They come to us one time, and then after 3 months, they come for 3 months control, and then they come for the control every year, at least till the first, let's say, 3, 4 years. And then we move the patient to the 2 or 3 year control interval as soon as we see that this is stable. Dentist technician Sanela Lazinica, also from Montenegro, actually. She will give a lecture about the production of the prosthetic workpieces. This will be done here in our lab. In this building, there's a classroom for the implantologist, and we have a classroom for dentist technician also here on the first floor. And there are scanners and milling machines, and sintering ovens, and so on, where we train dentist technicians. Yeah, Professor Alexander Lazarov is one of my oldest students. So he came to our team approximately in the year 2005 or 6. And since then, he works with the corticobasal implants, first, of course, with the BOI implants, later corticobasal implants. He's a surgical and prosthetical specialist, first class IF teacher, member of the IF board. So he knows really how this is done. He's also teaching one day. Professor Jan Vares from Lvov University is craniomaxillofacial surgeon, head of department, and he talks about combination with the chaos implants or with compression screws, with the bone augmentation done by dentine. It's actually a dentine augmentation, also about PRF. So his topics are, let's say, a little bit mixed, but it's very interesting because he's combining these methods of augmentation with the immediate loading protocols for the implants. And this is, of course, a little bit strange, because how can you do a bone augmentation then at the same time work in an immediate loading protocol? So he will show you this, how this is done. And of course, these augmentation procedures are improving a lot the volume, and thereby also the aesthetics. Dr. Fodor Kalin is also surgical and prosthetic specialist. First class IF teacher. He talks about combination of chaos implants, of compression screws, and BCS implants, or corticobasal implants. So this is, of course, not so easy to understand how these two implant types can be combined in an immediate loading protocol, because there are differences in the stiffness of the implants, and if different implants in this bone implant prosthetic systems have a different stiffness, then very often the damages appear on the stiffest component of the bibs, and this has to be avoided. So we need some minimal stiffness everywhere, basically, and Dr. Fodor will show you then how this is done. Well, that's about the teachers. There are in this prospectus also some testimonials. For example, Dr. Yunus Uguryan from actually Romania, but he works now in Germany. He took over actually my old clinic in Germany. And he works only with these symptoms. He does nothing else, no root canals, no nothing. They don't work on on Krankenschein or for the state, for the national insurance, but they do only this. Actually, most of my former students do only this, and it's also enough. I mean, for example, looking back on my working day today, I started in the morning, 9 o'clock in the clinic, and then we were equipping 4 patients with 8 jaws. I mean, full 8 jaws, upper and lower jaw, with implants. And then the impression was taken by the prosthetic doctor, by Professor Šipić and her team. So if you do 8 jaws per Then you don't have to worry what else to do. I mean, I didn't get the idea to do a little root canal in the evening, just to improve my pocket money. No, this is, I mean, we are completely on a different wave. We don't want to do any dentistry. We just want to take teeth out. We touch teeth only to remove them. This tooth extraction, which might seem a little bit strange to you now because you spent 5, 6 years in the university to get you the license to fix teeth, and then I come and tell you, look, forget it. Uh, Pull them out at the right moment, and you will make the patient very happy. And actually, this is my view on things. And you see, the dental chambers, they were for decades, maybe even centuries. I'm not sure how long they existed. They were always advocating to save teeth, and I think the safest place for the tooth is, for example, here, in this pocket, because there's no caries, there are no bacteria, there's also no attack from uh, any acids and so on. So we recommend, I mean, we don't want to steal the teeth away from the patient, so we give it to the patient if they want, but better to keep them somewhere and not in the oral cavity, because there they will only be suffering, creating problems. And what the patients, of course, hate most is the pain and infections and the costs, of course, not to forget the costs. Yeah, this takes me to the next important point is the cost of implantology. In the old times, I mean, when I think back to the times when I was putting disc implants or these BOI implants, these lateral basal implants, and one implant with the abutment and the cutter, we had to buy the cutter always separately, also one single-use cutter, and this was around 700 Swiss francs. So 700 Swiss francs is of course quite a lot of money, and that's why we equip many patients with a kind of all on four. We put implants only in the seven, the three, the seven, uh, and we made a roundhouse bridge, metal ceramic bridge on those four implants, and this worked very well. And the idea to work with so few implants came only because it was so expensive to buy these implants. Now, if you look at the prices today, you get implants for well under 100 euros in most of the countries. So you're not limited with the implants. If you think I put 4 times 700, 2,800 Swiss francs um, for four implants, and I would put again 2,800 today on the table, so I would more than 28 implants. So this is enough for two jaws. So I mean more than enough. So this has changed. This is a lot in our favor, and in order to treat every patient with oral implants, and this I think is the idea, and this is the plan, or must be the plan, to remove the teeth in the right moment and to give fixed teeth. We need simply a lot of implants at a good price, and this is nowadays available. So the door is wide open for this type of work on your patients. Now, of course, patients are they were brought up with the idea that the teeth are going to be saved, but I mean, I don't talk about tooth saving anymore. Actually, I talk about, if I send patients home with the teeth in the mouth, I'm sending them home with a lot of their own problems. And this is not what I would like to do. I mean, like every doctor should plan to do a treatment where the patients are happy and they can go home, they can live with their family, spend free time, work, whatever they want, but they should not sit on our chair. When we give them the implants, let's say upper and lower jaw completely, we usually install this in a way so that we will never have to make a corrective intervention. Of course, we have to adjust the base of the bridge and we have to adjust the occlusion. Later on, maybe we have to increase the occlusion. For example, with the metal to composite bridges, we had to do this quite often. But in general, I mean, the patients which we send home with two jaws on implants, they are done. I mean, they should not come back. And really, the big majority of the patients will come back only for controls, but they come never back for repairs. There's almost never. Let me just look at the chat. Wer kann Ihre Nachricht sehen? Tippen. Oh, I don't think that anything was written here. Okay, this should be answered. And now I want to go with you through this course schedule in detail. So this is what you're going to learn in Belgrade. This is, for example, from the course which just finished, the January course in 2021. There's a lot of information about the course, about how to go there, how to get there, how to find taxi, and so on and so on. And finally, we come to the course. The first lecture is Introduction into Corticobasal Implantology, definitions, terminology, background and science, development, and so on. Comparison to two-stage implants. This is quite a long lecture, which I'm giving is about 2 hours. Then the next lecture is about the 16 IF methods. Sorry, I make this a little bit bigger for you so you can read it. The lectures I have different colors here because they are given by different professors. In the afternoon, Professor Konstantinovic will come in and he will talk about single tooth replacement with corticobasal implants, loading and treatment protocols in implantology. And then at the end of the day, there will be a quite long lecture about treatments around and inside the maxillary sinus, so what to do if we have to anchor inside the maxillary sinus, what to do if we want to put a zygomatic implant, and of course this will go through the maxillary sinus typically. I mean, it's the easiest to go through the maxillary sinus, and we of course recommend this. And so these are the lectures of the first day. Then on Tuesday we talk about bone physiology. There's the part number 1. It says here working with the bone and not against it. Well, all this bone augmentation, I would say this is working against the bone. So because materials are brought in close contact with the bone, which should then turn into bone. Of course, they don't turn into bone. Nevertheless, this augmented area can get hard, even very, very hard. But I think this is not something that we should do because we see a lot of failures with these bone augmentation. I mean, even in the early phase. Then if you learn about the bone, you will understand why immediate loading is the protocol. I mean, this is how it's done. This is what the bone is ready for. So please forget the idea that the healing time is necessary and that we all have to wait for osseointegration. I mean, I mean, I'm not saying it doesn't work. Of course it works, but this is a very special case. The regular case for bone is to work in immediate loading protocol, simply to work when the forces appear. And this is possible for our field in implantology as well. So then I will show you how to find bone, or even if there is no bone, how to kind of smell where the bone is. Of course, nowadays with the technology of CBCT, you can find every little piece of bone easily. The other question is can you then reach it in this clinical environment when you have to do it, when you have to put the implant? How can you be sure that you reach it? So I suggest that you better learn very exactly about the anatomy so that you can work without CBCT. This is actually what I'm doing. I don't like to use CBCT. We use the CBCT only as a diagnostic tool after implant placement. So we will do our implant placement on the basis of a panoramic picture, and then when the patient goes to the first X-ray control, we do CBCT. And it's not that we couldn't see things so well on the panoramic picture, but we on the CBCT we can see really every thread of this corticobasal implants, and we can see if it's really in the second cortical, and if it's not in the second cortical. Then we see immediately with the CBCT where the second cortical is, the nearest second cortical, and we can do some early corrective intervention before even prosthetic is placed on there. We are a little bit under the time pressure because the period from implant placement until the start of the osteoidal remodeling, this means the softening of the bone, is 72 hours. So we have 3 days time to fix our splinting, to fix our bridge. I mean, 3 days is anyway a lot, especially for the patient is a lot. If you wait 3 days for teeth and that you can eat properly, this is of course quite a distance, 3 days. Huh? So sometimes we make it on 2 days. We will show you this year how it's done. And in any case, on day number 3, all patients which we treat will receive Their bridges. For example, today we had these 4 patients with a total 8 jaws, and they will be ready on day 3. Actually, tomorrow is the first day actually that we count, the second and third. So basically on Thursday, these bridges must be cemented, and on Friday we will control the patients, and then we go to the weekend. As you can imagine from let's say financial point of view, there's quite an interesting job. If you can do 8 jaws in 1 week, you don't have to do anything else. Okay, let me explain this in careful words. Huh? So, I mean, we are okay with what we get for that patient is also okay because they really make a big step into the future. They don't have any problems, and many patients who come to us to the control after, let's say, 5 years, 7 years, 8 years, uh, they tell us, I mean, almost everybody tells us the same story. And the story goes like this. Why didn't I meet you earlier in life? No, why? I mean, I have these implants now 5 years, everything was good. And it's unimaginable how much money and time and fear also was spent or happened at the time when I had the teeth. So I mean, our patients tell us, please tell anybody to take the teeth out. And actually, we can do it. We are no, the regular dentist will never take the tooth out, but we take them out because our product is better and our bridges are working long term successfully. And by doing so, actually, the regular dentist, has to how to say this. I mean, as long as the teeth and the mouth, the dentist has its hand on the balls of the patients. I hope you understand this in English well. And as soon as we take the teeth out, patients are happy. The balls are free. Nobody can come there and fiddle around on the teeth. Teeth are gone. Teeth anyway make 99% of the problems in the oral cavity. So I don't think teeth belong there. I mean, they're troublemakers. So, and this is actually what we are doing with this implant technology. So your clinic will completely change after you work with this corticobasal technology. You will get completely different customers. You may have in the beginning a little bit discussion with your patients. You should be maybe a little bit careful. For example, if you did some big crowning to some patient in 2 jaws, I don't know, 28 crowns, 2 years ago. I mean, maybe not to tell these patients so quickly about oral implants, let time pass by. So, I mean, so that the kind of in front of their internal calculator that this is kind of written off, and then they can invest into implants. I mean, this is only my advice. So, we don't have this problem because we don't treat teeth. We never do crowns. So everybody that walks in the door gets these out. Then Professor Šipić, she talks about treatment planning and prosthetics work. This is a 90-minute lecture, and it's very, very intense to listen to this. Then she talks about adjustment of musculature surfaces and the principles of maintenance. So what are we doing, in the control appointments, and what is important, how to set up the bite, and so on. So this is her topic. Then again, Professor Konstantinovic talks about treatment in the mandible at different stages of atrophy, which implants are used in technologies. And then he has 2 lectures about implant complications. There's also very interesting lectures about bleeding, about infections, about infections which are spreading, and so on. I mean, this is a very, very good topic. Professor Konstantinovic is a very experienced speaker. I mean, full professor, head of department of the maxillofacial surgery. So he has really seen everything, and he has all the answers that you might have to him. Yeah, the Tuesday finishes with a choice of bridge material. Here the question is discussed. Yeah, should we use metal, ceramic metal to composite, PMMA, or full zirconium? As for us, we are answering the question always the same way. We will do full zirconium bridges. I mean, really full anatomic zirconium bridges. That's what we do. This is, in our view, the best. Very, very rarely we have fractures of these bridges, so patients then call us and they tell us, I don't know, here the upper bridge is broken. As we work in a digital protocol, we call, of course, immediately the laboratory, and we ask the laboratory to do the upper jaw again for this patient. They have still the STL file, and they can mill the bridge, they can print it out if it's in composite, for example, but they can mill it, they can sinter it. And when the patient comes, let's say a few days later for this appointment where the broken bridge is taken off, the bridge is ready. So basically, we can just cement a new bridge. So this is something that you can do if you have a digital production. Let me just see the questions. Neue Nachrichten. Ah. Yes, there are no slides changed. Yeah, this is simply a lecture. Um, yeah, I mean, this is not a PowerPoint like I don't know, 2 weeks ago, but I'm talking about the program, and this was actually the program which was running 2 weeks ago, and so I'm explaining you what you will hear on this all-in-one week course, why it's important, and why you should come there. So then the second part of bone physiology will be taught of, and then we look at some surgeries which we have recorded on films. There's quite an impressive film where I do a lower jaw, full lower jaw, and the film takes 8 minutes. So you will see that this procedure is also very fast. Of course, I'm experienced, but you can get experience quickly if you, of course, if you do this a lot. And this, of course, very good for the patients. Today, I took out 4 Straumann implants from a lady with a strong atrophy in the lower jaw. And I mean, to take out those 4 implants and to put 5 new implants into the anterior lower jaw, and of course also to add implants in the distal mandible, this took me about 50 minutes. So as you see, we are really saving time, and that's of course very much appreciated by the patients. This lady told me that putting those 4 implants by a Swiss specialist took her 3 hours, or him 3 hours. And of course, we can only laugh because this is what we are doing is so fast and so easy and so predictable also. It's a completely different type of implantology. But of course, I mean, this was a really high atrophy case. I mean, it was really, really no bone, but no problem to fix this mandible. Maybe for the next curriculum, I will try to find this case of the panoramic picture before and after. Okay, so Professor Konstantinovich talks then about bleeding complications, about odontogenic infections. That's actually 2 lectures, first and second lecture, and then I will talk about changes in the morphology of the jawbone. You may remember if you are putting a full denture in the upper and the lower jaw, that over time this starts to rock, so then you have to rebase it. This is a typical protocol of how to prolong the life of this removable denture. And of course, these changes in morphology in both jaws take place with and without the full denture. I mean, simply if you remove the teeth and you put the bridge on implants, especially on our implants, which are not osseointegrated in the first cortical, you will see morphological changes. For example, disuse, atrophy, you see results of increased and decreased loading. And this has to be addressed. So during the control appointments, we have to make sure that our patients have stability, that the gap is big enough, and so on. Yeah, then the lecture from Professor Vares about the PRF and dentine graft. Again, Professor Šipić will talk about prosthetic changes on cemented bridges during the healing phase. And Dr. Karin Fedor talks about TPG Uno implant. This is a polished compression screw implant, and about the combination of PCS and COS, and actually TPG Uno implants in full jaws or in segments. This is a very interesting lecture because it gives you clear rules what to do and which implant can be combined. Then Sanela Lasinca will talk about the technical things. Also, she has an exocad evening demonstration. It's usually on Thursday. Then the afternoon, Thursday afternoon, is usually reserved for Professor Ihde, Antonina Ihde. She talks about prosthetics, a lot of topics actually, and she also talks on Friday morning. So this is totally one day, one full day about prosthetics, and this, I mean, you cannot miss this. Is very important. Both the prosthetic lectures of Antonina Ihde and Oля Šipić are strongly recommended, and in general, as you see, this is quite a schedule here. So we have 62 teaching hours in this week. So if you kind of intend to enjoy also the nightlife in Belgrade, I recommend to come to the course and then stay one week longer. Then you can enjoy the nightlife in Belgrade. But during this week with the course, I mean, you better go to sleep because we will really stress you. We give you a lot of information and we keep you very busy. Lots of questions are answered or also asked to you. Of course, we want to make sure that you learn and that you understand what you have learned. So don't expect to see too much from the nightlife in Belgrade during this week, or you will miss a lot of the course. And actually, the course is what you came for. Huh? Again, there are lectures from Sanela Lasinica about the digital workflow. It's also possible to use data from standard cases. On new cases, the whole jaw will be moved over on the new model. Maybe you will not do this at all. Maybe, I mean, like me, for example, I'm a surgeon, and I would also never do prosthetic work anymore. Also no lab work. But there are doctors who do it all. I know a number of doctors, for example, in Russia. They are booked for 2 years ahead, really 2 years ahead booked. They have to plan their holidays 2 years ahead because there are so many patients, and some of them are simply doing, yeah, case by case, and they do the technical work also. It's not so complicated to do this with the computers nowadays. And they simply say, look, we do this all ourselves. We don't have to rely on the quality of the work of dentist technician. And with these machines, with the sintering oven and so on, we have everything under control. And I think it's a very good point. Yeah, then on Friday afternoon, Professor Lazarov comes. He talks about his research about implant survival, complications, and changes in the quality of life. So he has published a lot about his patient clientele, and he has invented his own technique. It's called soft tissue augmentation and deep cementation technique. This works with metal ceramic bridges. It's very interesting to see how this is being done. It's more or less exactly the opposite of what I'm doing, but he's doing the cementation deep in the extraction socket. He gets, of course, very, very good aesthetics. I mean, this is really unbeatable, must say. Um, but you have to follow the rules exactly like he's explaining them. Then you will be successful with this technology if you want to use it. Then typically there's another dentist technician, Sergei Yablakov. He came actually from Russia. He works now in our clinic in Montenegro. This lecture can be in Russian language, of course. Sometimes it's in English language. So there are two teachers for the laboratory usually on the course. And of course, you can discuss with these teachers a lot. And I want to mention here also that the dentist technician courses, which run 3.5 days, are running parallel to the dentist or implantologist course, which we have here in the second floor of the building. So you can bring your dentist technicians with you, and it's even highly recommended to do this so that you are both trained at the same time on the subjects which you need, and so that you can immediately start a very, very good cooperation. We do this because the experience shows that if you work with a dentist technician who is not specially trained for this technology, he will not understand what you are saying. He will not believe that this is possible, what you ask him to do. He will citate his teachers and the textbooks of dentist technician that this all is not possible. So better come with the dentist technician to us, or with two technicians, better, so that you have enough technicians who can do in the end this work. My rough guess is that a good surgeon requires 3 prosthetic doctors and 8 dentist technicians to work like uninterrupted. But these 8 well-trained dentist technicians, I mean, they don't fall on the street from God, but we have to train them, and we have to inform them about how to do it, and they will not know that this is possible or how this is done. So when you build up your clinic with this technology, you will have to send for sure dentist technician to the course. Now, of course, the question who pays this, if you pay this or the dentist technician pays this, but we have no problem sending our technicians, for example, even on expensive courses. We work with our technicians, for example, with the Sanella, I think we worked 12 years. So every cent which we invest into her education was worthwhile. And even she became the teacher, and she teaches now others. So please don't think about the money. You're on the way to become multimillionaire, whatever, in dollar or in euros. So you should look at this aim and how to reach it as fast as possible and as safe as possible, and not to save 50 euros on education. I mean, this is absolutely wrong. Because if there's a small thing that somebody doesn't know and then the bridge breaks, you have to do it again and guarantee, then better pay the 50 euros or 100 euros for the education. Okay, on Saturday, Professor Lazarev is also talking in the morning, and then various lectures are being given. Lecture about botulinum toxin, how to use it to bring the chewing forces down. That's, of course, important in the immediate loading protocol. Again, a lecture of Sergei Yablakov on setup versus digital modulation. Then I would say very important lecture about the open bone wound. So this concept of the open bone wound must be explained and understood. The open bone wound is called open bone wound because the implants that we put are in contact with the oral cavity. Of course, the cementing abutments are in the oral cavity, and the implants are in the bone. And between the bone, let's say even this is a second cortical and the oral cavity, there will be always a gap. So because it's not osseointegrated, the open bone wound is really open, so liquids can flow out. Liquids from, for example, saliva can flow in. It depends on the pressure gradient. And you have to understand what an open bone wound problem looks like and how to solve it if it happens, or how to avoid it. Yeah, on Saturday, usually we have the open end. It's called dinner and dinner debates in the classroom. So we eat in the classroom, and then there are a lot of lectures. There's only a few lectures mentioned here, many of them by me. Also, Professor Vares is talking about periodontal pathology and periodontitis and two-stage implants. Also, a very, very interesting lecture. Then on Sunday morning, lecture about bone augmentation, how to avoid it, when to take it out, what to do with it. Because, of course, more and more patients come with the bone augmentation to us, and then usually we have to remove it because it's too dangerous. Also, in this context of the open bone wound, it's too dangerous to leave this in. Then slowly the week ends. This lecture on stiff and elastic components of the bibs describes how different designs of implants, if they are used in one bridge, actually this is about the bibs, how they influence each other and what works and what doesn't work. This lecture is important to understand because you will have patients who come to you with, for example, 2-3 two-stage implants, and they, of course, have the expectation that they can keep them in. But I can already tell you now, we will always take them out. So two-stage implants, they are not elastic, not isoelastic. They are simply stiff, and it is in reality not possible or not easily possible to combine stiff and elastic implants. So then you will get your certificates, and after 4 o'clock approximately, we do a hands-on course so everybody can practice on models. So, sorry, this is the outline of this course. I invite you very much to come to Belgrade. Better maybe take a few courses before, for example, in Bogota or in your home country if they are available, and then you are prepared to easily learn the rest, or to learn get this big bunch of information which you will need later all your life. So if there are questions, I'm ready to answer this. Let me see. Yeah, wonderful lecture. Thank you also. Thank you for listening. Other questions or other comments? I mean, we have time here. We can discuss. You can write it into the chat and I will answer, of course. Nobody. Okay, so thanks for listening and see you soon. I mean, we continue this every 2, 3 weeks. We have this type of webinar, and I might even give a lecture from the course to see what it's all about. And then I hope to see you here in Belgrade. Thank you very much.